Good morning. Well, Albany doesn't have a team that rivals the Red Sox, but I've actually lived for the past 30 years in Washington, D.C. So in addition to the Yankees, who will always be my favorite, sorry, I was born and raised on them, I've become a Nats fan. They didn't do so well in the playoffs this year, but we watch now both the Yankees and the Nats in our house. So first, before we begin with the panel, I would like to thank, on behalf of EPA, our distinguished partners who have participated with us in putting this summit together. The U.S. Department of Health and Human Services, HHS, U.S. Department of Housing and Urban Development, HUD, the New York State Department of Health, the New York City Department of Health and Mental Hygiene, the New Jersey Department of Health, and the Puerto Rico Governor's Office. We all together recognize the importance of the subject that we're addressing today, asthma as an important, not just a medical condition, but as Dr. Landrigan put it, an epidemic in this country, and the importance of finding sustainable funding for dealing with in-home interventions. As the other speakers have remarked, asthma affects nearly 26 million people in our country and is one of the most common chronic childhood diseases. I think we all know that it affects 1 out of 10 American children, so you can hardly have any family that is not affected by it. My own son had it, even though we grew up in a very easy, clean neighborhood in Washington, D.C. Asthma causes these children to miss school days, we know that, and it causes their parents to miss too many work days as a result. And in addition to the personal toll and the family toll that it takes, as people have mentioned, we're spending $65 billion every year for the asthma-related costs, including hospital stays. Now, with that price tag, wouldn't you think it would be sort of obvious that when we've got an inexpensive and easy way, relatively easy compared to other solutions, of using at-home asthma interventions to reduce this, that we could do a better job. And EPA is committed to joining with all of you in trying to do that. From EPA's point of view, one notable fact about asthma is that it is not an equal opportunity affliction. Asthma disproportionately affects low-income and minority communities, as we all know. Hispanic children face a higher risk of asthma than their white counterparts. Hospitals treat black children for asthma at twice the rate of white children, and asthma-related deaths among black children are 4 times that of white children. So EPA does see these disproportionate effects of asthma in our everyday work, and it doesn't surprise us anymore because in our journey we've always known that air pollution is one of the key causes of asthma, and that low-income and minority communities too often take the brunt of the worst air pollution in our country. The communities too often live too close to industrial facilities, to highways, to ports, and to other sources of serious outdoor air pollution. So to EPA, with our primary responsibility having traditionally been in the outdoor environment, this is an environmental injustice issue. But over the years, of course, we've learned that outdoor air pollution is not the only cause of asthma and that there are dangers, surprising dangers, in the indoor environment as well, including such common things as mold, mildew, and even common cleaning products that most of us probably have under our sink. These indoor sources of air pollution, we now know, add to the disproportionately high pollution burden that low-income communities already face from the outdoor air and the location of their communities. But there are easy ways, relatively easy ways, and inexpensive ways to treat this, and that's why this summit, where we are all joined together, is focused on one specific way to get at this problem, which is in-home asthma interventions. According to the National Asthma Education and Prevention Program, comprehensive asthma care has 4 elements. 1, of course, high-quality medical care and management. 2, self-management education. 3, environmental remediation or in-home asthma interventions. And 4, medications. So evidence shows that using these tools to control asthma improves the health outcomes and does achieve a cost savings. And yet, comprehensive management care is still not routinely reimbursed by the insurance companies. Although recent health care reforms have increased states and private insurers' opportunities to cover the costs of in-home services, many states struggle to transform these services into real policy. And that's why one of the main challenges we must address today is how to find more sustainable sources of funding for those in-home interventions. I hope we have gathered here today enough experts on this subject and enough people committed to finding the solution that we will be able to find ways forward together here. Our panelists on this panel are from regional, federal, state, city, and territorial governments, and each of them will speak to their commitments to move in this direction. I can assure you that EPA is committed to that goal, and we will do all that we can do to participate in this very worthy endeavor. So at this point, it is my pleasure to introduce our panel. As Misha mentioned, we will not go through the bios. They have, between them, it would probably take about 2 hours to get through all of the distinguished accomplishments of this panel. But they are in your booklet, so if you would like to look at the bios there, you can find out more about each of our speakers. We have Susan Horowitz from HUD, who is a Healthy Home Specialist, Michelle Davis, the Regional Health Administrator of the Office of the Secretary of Health in Region 2, Ricardo Holligan, CMS, Division of Medicaid and Children's Health Operations, Cheryl Donald, the Deputy Regional Administrator of DHHS HRSAORO. Now, you all probably know the full words for that, so I'm not going to spell them out. She's also the USVI lead, which is important. Daniel Cass, the Deputy Commissioner of Environmental Health for the New York City Department of Health and Mental Hygiene. Douglas Fish, Medical Director of the Division of Program Development and Management, Office of Health Insurance Programs of the New York State Department of Health, and Jesus Irizarry, the Health Advisor of the Puerto Rico Governor's Office. So with no further ado, I would like to ask our panelists to please begin to give you their perspective. We're doing this in a TED presentation today, so we've asked each panelist to please spend 3 to 5 minutes giving us your highlights, and please start with one fun fact about yourself. It could be as simple as, where were you born, and where do you come from?
Good morning, everybody. Good morning. Okay. I'm very pleased to be here today to share some information with you. My name is Michelle Davis, and I serve as the Regional Health Administrator for the U.S. Department of Health and Human Services. And thank you, Catherine, for the introductions of this panel. First, I'd like to thank the organizers of the Regional Summit on Sustainable Funding for In-Home Asthma Interventions. That would be the major leaders, EPA, HUD, and of course, staff from HHS. The information on this panel today that's going to be shared with all of you is very important. The Office of the Regional Health Administrator, which I oversee, I have a number of staff that are subject matter experts in women's health, family planning, minority health, HIV/AIDS, infectious diseases. We do the broad range of activities across public health and health care. And we work with all of our partners within HHS, so our partners at CMS, at HRSA, the Indian Health Service, CDC, to support initiatives that come out of HHS. And so we work with partners in New York, New Jersey, Puerto Rico, and the Virgin Islands, academic institutions, community-based organizations, faith-based organizations. So we work with anybody on education, outreach, policy, implementing programs so that we can have healthy communities. We, in particular, that's related to this event today, I have a subject matter lead on environmental health and environmental justice, and she's actually in the audience here, Kadish Altador. And she is working with us and with EPA to implement our regional interagency working group on environmental justice, where we've identified 6 communities, and we're working with them to address issues of environmental justice in their communities. We also have many of our activities, or most of our activities, are aligned with the priorities of eliminating health disparities and achieving health equity. So we know that asthma makes breathing difficult for millions of Americans, and we've heard some data from Catherine. Approximately 40 million people in the country, including about 11 million children, have been diagnosed with asthma in their lifetimes. And I actually also have asthma, so I guess maybe that's one fun fact.
Or not so fun.
Maybe not so fun, but I grew up in Detroit, so that's where I hail from. And of those 39 million adults and about 7 million children still have asthma. There's a definite national impact on health for asthma that we all know about. And the estimated total cost of asthma to society, including medical expenses, is about $50 billion per year. We have loss of productivity resulting from missed school or work days, premature death, and that was about $56 billion. During 2001, and this is data from the CDC, 2001 to 2011, the number of persons with asthma in the United States increased by 28%. In most cases, the causes of asthma we know is unknown, but there are multiple host and environmental factors that have been identified which may be involved in the development of asthma and the exacerbation of asthma symptoms. Some of the exposures associated, which you all know with asthma attacks, include exercise, airway infections, airborne allergens, pollen, mold, animal dander, tobacco smoke. We have a major initiative on reducing smoking. Also, research has been done to examine the relationship between obesity and the development of asthma, and one highly recognized program that's addressing childhood obesity is the First Lady's Let's Move initiative, which my office also oversees. Although there is no cure, asthma can be controlled with appropriate medical care, and the exacerbations can be prevented by avoiding exposures. The good news is that it can be managed and treated so that affected individuals can live healthy lives. HHS agencies are very involved in conducting research, developing policy, and funding programs to address asthma prevention, treatment, and control. And we also work with partners on awareness activities, and including for November, which is Chronic Obstructive Pulmonary Disease Awareness Month and Lung Cancer Awareness Month. EPA and HHS children's asthma education booklets have been distributed by staff, and they deal with the control of asthma for both indoor and outdoor exposure. We also have worked with the Virgin Islands very closely on strategic and coordinated efforts for many different areas of public health, including the reduction of asthma. And to conclude, I'm very happy that, in particular, this conference is co-sponsored by HHS, EPA, and HUD because it aligns with one of the priorities of HHS, meaning health in all policies, meaning all sectors play a role in improving health and wellness. And just recently, in this past week, CDC has put up a website with tools for putting the social determinants of health into action, which can also be utilized to help us to address asthma. So thank you very much.
Okay, can you hear me? Okay. Good morning. My name is Ricardo Holligan, and I apologize, but my bio isn't in the course of some things because I was a late scratch. The person that was supposed to do this had the medical procedure this morning, couldn't make it. And there was some confusion about who was going to do it, and even up until yesterday, I didn't realize that I was going to do it. So a little fun fact about me is that my career actually started in the Department of Health here in New York City, and I worked for the Lead Poisoning Prevention Program, so I know a little thing about, environment and disease. What CMS is, we operate the Medicare program from beginning to end, from payers to regulations, and what we are when it comes to Medicaid, we are actually, I would say, the financial partners of the states in operating the program. We leave it to the states to really implement the program, through a contract that we have with them called the Medicaid State Plan. And my division, we operate in terms of when the state wants to make changes, when they want to do different things in terms of disease management, we're the people that they come to say, hey, we're going to make changes and will you let us do it? And most of the time, we approve it, most of the time. One thing, though, I just want to say that for a long time, CMS has really been a payer, especially when it comes to Medicaid, and that's what we do, we pay. We pay as long as it's feasible, federally responsible to pay for it, we pay. But over the last couple of years, through Congress, we actually now have something called the Innovation Center, which allows us to actually now fund grant projects, to try to do innovative things like asthma reduction, prevention. So one of the things that happened this year throughout Innovation Center is that they held a summit where they gathered together some of their awardees that they gave grants to try to come up with innovative models, and one of those models that they wanted to focus on was pediatric asthma. And at that summit, it was charged with the group wanted to, step back a second, who was there was, number one, our awardees, but we also invited some payers and providers to the summit to come up, try to come up with some ideas how to implement value-based payments around pediatric asthma. And one of the things in the asthma that they focused on was to try to find goals, metrics to look at, try to estimate the results. I'm sorry, in the wrong part of my presentation. That's what happens when you do it last minute. Okay, but no, one of the things they want to do was to look at, identify prompting strategies that they could develop these value-based payments around. They want to find, to look at, try and find metrics that are important to states, MCOs, and looking at these value-based payments. And one of the things that they took out of it is that they wanted the awardees to come up with models, different models of how to create value-based payments in MCOs and providers and organizations. They wanted to have these models to be vetted, and at the conclusion, they'll try to, at least by the end of next year, have at least one contract around the country that would use some of these models, to try to see how they would work, and can be sustained, and maybe even can they take these models and try to use them on different other diseases. But my point is that CMS now, we are dedicated to trying to not only just pay for services, but now try to, do our part in preventing diseases and helping people, to live better lives. Thank you.
Good morning. Hopefully everyone can hear me. I thank you, Catherine. So I think my first task is to demystify all of those acronyms that you use to introduce me. So good morning, everyone. My name is Cheryl Donald. I am the Deputy Regional Administrator for the Health Resources and Services Administration, which is our acronym HRSA. And we are in the Office of Regional Operations. The New York Regional Office is here in Region 2, and we cover New York, New Jersey, Puerto Rico, and the Virgin Islands, and we actually have a sub-regional office in Puerto Rico that I think many of you have probably interfaced with at some point. So I want to bring you greetings on behalf of our Regional Administrator, Mr. Ronald Moss, as well as our HRSA Acting Administrator, Mr. Jim McCrae, who is in our headquarters in Rockville, Maryland. So the HRSA Office of Regional Operations was what we consider the face of HRSA. We cover the 4 jurisdictions of Region 4, and we serve as the local representative for the HRSA Administrator. We also serve as a liaison between our 279 grantees that are here in Region 2 and the bureaus and offices of HRSA. I'm joined today by my colleagues. You've already had the opportunity to meet Dr. Tanya Bagan-Raggio-Ashley. I think she's kind of floating around. She's back there. And then also Dr. George Parakis, who is in the back, if you could just stand up. He is our lead for rural as well as tribal health activities in Region 2. And then also Ms. Shirley Smith, who has joined us as well. She is the regional nurse consultant for our HRSA Maternal and Child Health Bureau. So just wanted to put some connection there for our federal team. Also in our office is Dr. Chandi Ghosh. She takes the lead for our activities in New York State. as well as in Puerto Rico, in our sub-regional office, we have Dr. Clarissa Malave, who is our lead for Puerto Rico, as well as Dr. Madeline Rosse. So I say all that to say, as we continue on with our dialogues here today, if you have any questions or concerns around how HRSA can help support your efforts, feel free to reach out to myself or any members of our team, even if they happen to not be here this morning. So I want to talk a little bit about HRSA. HRSA is one of the 11 agencies under the U.S. Department of Health and Human Services, as Dr. Davis has shared. We're the primary agency responsible for increasing access to health care for people who are uninsured, geographically isolated, or medically vulnerable. This includes people living with HIV/AIDS, pregnant women and mothers, their families, and those who are in need of high-quality primary health care. Our FY15 budget, we're still working on FY16, is approximately $10 billion, and it supports states, local governments, as well as community-based organizations in delivering that comprehensive, high-quality preventive and primary care to patients who may not have the ability to pay for that. We also train and support a multidisciplinary clinical workforce designed to treat the whole patient through culturally competent and accessible care. And we build healthy communities through programs like home visiting, Healthy Start, and rural and women's health initiatives. HRSA supports the training of health professionals through our National Health Service Corps and our Nurse Corps. And we also work on the distribution of providers to areas where they are in need most, whether that's isolated areas in rural America or in some of our underserved urban areas, such as East Harlem here in New York City. Some of you may not know that HRSA also oversees our organ donation, bone marrow, and cord blood donation programs. We also compensate individuals who have been hurt or harmed by vaccinations, and we maintain databases to protect against healthcare malpractice, waste, fraud, and abuse. So we're also often referred to as the Access Agency. Our Community Health Center program is funded at about $5 billion, and we support 1,300 organizations that operate over 9,000 service delivery care sites to nearly 22 million patients. Many of those health centers are actually located right here in the neighborhood. 1 in 3 people living at or below poverty rely on HRSA programs, and 35% of our health center patients are actually uninsured. So HRSA programs work to improve health equity by working to reduce and eliminate health disparities. Our uniform data system, which is our reporting mechanism for our health centers, indicate that at least 6% of health center users receive care for asthma, and many more are living with asthma and may not come to our health centers for care. Historically, HRSA has supported what we call the asthma collaboratives throughout the country. Many of the stellar programs are actually located here in Region 2 in our 4 jurisdictions. And these programs are no longer funded by HRSA, but many of them continue to live on in the asthma preventive programs of our community health centers. Our health centers also provide medication through our 340B drug discount program. And our health centers in New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands continue to collaborate with their respective communities to address the wide range of issues that impact children with asthma, as well as looking at programs around tobacco use, smoking cessation, and exposure to secondhand smoke. So we look forward, I'm getting the notice to stop. So we look forward to our continued collaboration with our fellow federal departments and colleagues on the panel, as well as all of you that are in attendance today. We thank you for this opportunity to dialogue in the conversation. Many of our HRSA grantees are here in the room, so please utilize their expertise around addressing the asthma issues. And I'll pass it over to my colleague from HUD.
Thank you. Thank you. My name is Susan Horowitz, and I'm the Healthy Homes representative for Region 2 out of the Office of Lead Hazard Control and Healthy Homes. One of the fun facts, I guess, is that before I got this job, I didn't even know that HUD had an office like this. And it's a terrific opportunity for us to get involved or to show the connection between health and housing. HUD programs and policies to impact asthma disparities. As part of the Federal Interagency Task Force on Combating Asthma Disparities, HUD's role include provision of resources to research the relationship between indoor environments and asthma, provision of guidance and resources to reduce physical environmental factors that may lead to or exacerbate asthma symptoms, promotion of the integration of health and housing disciplines. The provision of resources to research the relationship between indoor environments and asthma. We have a Healthy Homes Technical Studies grants. We give out, it's a competitive grant program. And what that program does is those grants, they developing validated assessment tools and improving environmental sampling protocols, improving upon current residential integrated pest management, IPM protocols, improving indoor air quality, evaluating the efficacy and cost effectiveness of interventions to address high priority residential health and safety hazards. And I might add, in our lead grant program, we have a set aside for the Healthy Homes Initiative. It's money that grantees can use to mitigate asthma triggers in the home by cleaning up mold, pet dander, and other triggers for asthma. It's not a lot of money, but at least it's a start. In terms of provision of guidance and resources to reduce physical environmental factors that may lead to or exacerbate asthma symptoms, HUD has produced, my office actually has produced recent guidance documents that include smoke-free housing, changes in the air, and I think some of you may be aware, most of you should be, that HUD just put out a proposed rule with a 60-day comment period to eliminate smoking in public housing units throughout the nation. And that's really a biggie. It's controversial. Just here in New York City alone, we have 178,000 units in NYCHA public housing. Hopefully this will get passed. Also, we have an integrated pest management program. Promotion of the integration of health and housing disciplines. We give priority points in certain HUD competitive funding applications for, and this is important, the coordination of housing rehabilitation with health and energy. Applicants are encouraged to coordinate the delivery of housing, repair, rehabilitation with community hospital or public health programs that utilize community health workers, promotoras, health educators, or similar positions that assess the indoor quality of home environments for conditions that may impact resident health. For example, in the coordination of rehabilitation activities with programs that assess the home environments of asthmatic children for asthma triggers. We do give points in our competitive grant program for that. So my office is making an effort to help reduce asthma in children throughout the nation. Thank you for inviting me.
Hi, everyone. Thanks for having me. I see a lot of familiar faces, but more importantly, I see people I don't know, and having worked on this for a while, that's really exciting. So fun fact, I was 10 years old in 1970 when the first Earth Day happened, and we were assigned to make a film with a Super 8 camera, if any of you have ever heard of those. And I grew up in the suburbs of LA, and we have a rainwater runoff, stormwater runoff system there, and we wanted to sort of show how bad the pollution was. And so Eric Varnon and I went down to we called it the Wash. I looked around, all we saw was sort of really nice greenery and frogs, and so being good 10-year-olds, we went back, and the next day we brought trash and dishwashing soap with us to pollute it. So I've been atoning for that sin ever since. So I'm from the City Health Department. We do a lot of stuff, and I'm just going to kind of try to highlight some of it that touches on these areas and then end with a couple of entreaties, I think. So the first and one of the most important roles we play is a regulatory role. We have authority over many things health-related, including some aspects that are housing-related. So for those of you who don't know, we have Article 151 in the Health Code, which, at least on paper, is among the more progressive pest-related codes around that essentially authorizes the health department to mandate integrated pest management in many circumstances. The realities of implementing that and enforcing it are quite challenging, but it does set a floor in New York City for the way we see pest control needing to happen to control triggers. We also enforce a variety of other related issues related to the indoor environment and to a lesser extent the outdoor environment. Probably the most significant contribution I think that we make as a health department to the issues that we're talking about today is really around surveillance. So I want to make a plug for a website that we call Environment and Health Tracking Portal. It's nyc.gov/health/tracking portal, where we put neighborhood level data up around a whole host of issues that relate to this issue to try to both explain what's going on, allow people to generate hypotheses, and we hope to become more and more indignant at the disparities that exist across the city in both not just asthma, as Dr. Landrigan has talked to us about, but also in the prevalence of pests and indoor triggers, and the quality of services associated with their remediation. So I won't talk about that data except to point out that when we have a 15-fold difference in the prevalence of cockroaches and mice across city neighborhoods, we know that the quality of the indoor environment, especially in housing, is probably the leading factor in explaining the disparities across the city in asthma symptoms and exacerbations, and that's what we really need to tackle. We also do surveillance on air quality, and for those of you who don't know, we have the New York City Community Air Survey, and I just want to highlight a couple of things that's important from there. One is the data really matters, and many of you are researchers and continue to do the work and get it out there. That found, for example, that air quality across the city doesn't vary really by income, and the great story there is that it helped to create a new set of stakeholders in improving air quality across the city. There's no question that the impact of poor air quality remains disparate and impacts low-income communities far greater than high-income communities. But higher-income communities have really terrible air quality in New York City relative to other parts of the city. So in my last minute, I want to cue up a couple of things. One is later today, my colleagues Carrie Olson and Deborah Nagin will be talking about an exciting study that we're involved in called a return on investment study. It's a randomized trial. And we're really trying to quantify the savings to the healthcare system from a very simple integrated pest management program to try to embed incentives into the healthcare paying system for paying for this. The one thing I sort of want to end with is that this is really an ideal moment for us to have this conversation between a consensus that's emerged scientifically about the importance of indoor triggers, the attempt and at times failure to grapple with them in the housing and housing maintenance market, the incentives on payers and healthcare systems to save funding, the reform of Medicaid, and the sort of desperate needs of communities out there. This is really the time to figure this out, and I think we're going to do it this time. The last thing I want to end with is a plea to also, in my sort of never-ending obsession around pests, to really think about not just how we pay for good pest control services, but how we leverage the dollars across systems right now that are utterly wasted on very poor quality pest control. Landlords buy services and they achieve very little. The EPA and the state DEC do virtually nothing to regulate the actual practice of pest control. They regulate pesticides, and we need to really think about how to make those dollars better spent. So I'll stop there.
Well, good morning, everyone. It's a beautiful sunny day here in New York City. After yesterday's rain, hopefully everyone is breathing more easily this morning. My name is Doug Fish, and I'm one of the medical directors in the New York State Department of Health, Office of Health Insurance Programs. A fun fact for me is I love the weather and meteorology. and grew up in central Ohio, a little town, Mount Vernon, outside of Columbus, about an hour northeast of Columbus. Been in New York about 22 years, and New York is my favorite state. Would like to, it's a great state. You have everything, right? We have everything here. Would like to thank Amisha and the conveners, HHS, EPA, HUD, and others for inviting the New York State Department of Health to speak to you on our Delivery System Reform Incentive Payment Program, or DSRIP program, and how it is addressing the asthma challenge. As we know, the health of our Medicaid members is not optimal when it comes to asthma. And this is borne out in our costs. So what I'm showing you is a little bit of data. Our annual emergency department spend per Medicaid member. And in gray, you can see that the average spend for the general Medicaid member is around $100 per year. This is data from 2014. It is about 2.5 times that for those Medicaid members with asthma. About 4 times that for our members, our HARP members, Health and Recovery Plan members, those with serious mental illness and substance use. And if you have the comorbidities of mental illness or substance use and asthma, the costs are nearly 7-fold those of the general Medicaid population. So if we look at the percentage of these HARP members with asthma, it is higher than what we saw for the 2013 numbers at 10%. It is 12% of our members with serious mental illness or substance use who have asthma. So if we look at the inpatient spend now, again, a similar array. In gray, the average spend for the Medicaid member for inpatient care is around $1,200. Over twice that for those with asthma, and for those with mental illness, substance use, and asthma, over 10 times that of the general Medicaid population. And I thought you would like to see what it is broken out for children as well, less than age 22. So this is the inpatient spend on the left and the ER spend on the right. And the statewide average is in orange at around a little over $500, and 2.5 times that for Medicaid members who are children with asthma at over $1,300 per year. And similar ER spend, around $95 for the statewide average, and then over $200 ER spend per Medicaid member under the age of 22. And then it's broken out by the 11 DSRIP regions, and you can see this pattern holds true. So the response is that in April 2014, Governor Cuomo announced that New York State and the Centers for Medicare and Medicaid Services finalized the agreement on the Medicaid Redesign Team Waiver Amendment, allowing New York to reinvest $8 billion of the $17 billion in federal savings that had been generated by the reforms for our 6.3 million members, with the goal to transform the state's healthcare system, bend the Medicaid cost curve, and assure access to high-quality care for our members. There are 25 performing provider systems through the DSRIP program. 10 are upstate, 11 are within New York City, 3 are in the Mid-Hudson Valley, and 1 on Long Island. And with asthma as an ambulatory care sensitive condition, and where the severity of illness is minor or moderate, this leads to opportunity to avoid hospitalizations and readmissions. These are the performing provider systems who chose from the menu of options of projects, asthma-related projects, and the one I'll focus on is Project 3DII, the expansion of asthma home-based self-management programs, which includes a home environmental assessment, education on the role of the environment in asthma control, modification of the home environment as needed, self-management education, as well as coordinated care and a root cause analysis when admissions and ER utilization occur related to asthma. These are the regions across the state, and as you can see, there is a focus in the most populated regions of the state for the performing provider systems who are choosing the asthma projects, and the golden circles are where there are also prevention agenda-related asthma priorities through either the local health departments or local hospitals. These are the metrics on which the asthma efforts will be monitored through the 5 years of the program. The Domain 2 are system transformation metrics, potentially avoidable ER visits and readmissions. The Domain 3 project-specific metrics are around prevention quality indicators for adults and pediatrics, ARC measures, and asthma medication ratios and medication management for people with asthma. And these are performance-based metrics from years 2 through 5. And then the Domain 4 metrics are population-wide asthma emergency department visit rates per 10,000 members from our SPARCS or inpatient database. And no healthcare reform is complete without also transforming how we pay for healthcare, and New York has developed a 5-year roadmap for value-based payments. On the left is an example of what would be the all-in ACO type of model of care, but we can have also bundles of care, either episodic or continuous Chronic care bundles and asthma is one of those under consideration, and there's been a pulmonary clinical advisory group meeting around asthma and other pulmonary conditions. So I'll just conclude in that the PPSs around the state are working with the asthma projects through the asthma coalitions and the Healthy Neighborhoods programs. The PPSs have submitted their second quarterly reports, and those are under review by DOH, and they will report quarterly, and payments are based on every 6-month reporting and outcomes. Thank you.
Good morning, everyone. I'm Jesus Urizari Mora. I come from Puerto Rico, and as a fun fact, we had a drought like for about 6 months, but it's been raining on the island for the last 2 weeks, so please don't blame me for the rainy day yesterday in New York. So I hope not me, don't blame me. I'm joined here by people from the department. I'm a public health person. I've been around in public health for the last 32 years. I'm a demographer myself, and I'm joined here by Dr. Jessica Irizarry, who is the Secretary of Health Promotion. Just please stand up so everyone knows who you are. Ms. Wanda Hernandez, she is the Director of Asthma Program in Puerto Rico, and Dr. Lourdes Soto Garrido, she is also Director of Research Institute for Global Health Education and Promotion. So they're really the experts. As I said, I'm not a physician. I'm a person from public health, and being from public health, I know the importance of prevention approach in asthma prevention. So I'm going to say a little bit about what we've been doing in Puerto Rico in terms of the asthma program. It has been in assistance since 2003 through funding from the CDC. Currently, it's been funded by the Preventive Health and Health Services Block Grant, and the main goal is to maintain an asthma surveillance system and to implement asthma control strategic plan with the collaboration of asthma partners, including Puerto Rico Asthma Coalition. The asthma program includes 3 major components: partnerships, surveillance, and health promotion and health education. Through partnerships, the program has been able to update the asthma strategic plan, recruit more asthma collaborators, maintain the surveillance system, increase asthma awareness, and educate people on how to avoid environmental asthma triggers, partner with local stakeholders, help residents manage their own health, and develop public policy, among others. As you see in the data, Puerto Rico has a very high prevalence of asthma among children and adults. For adults, it's about 10.6%, and for children, it's nearly 14%, which is higher than the U.S. These prevalence rates are higher among low-income and people with less scholarity. About 50% of the people with asthma in Puerto Rico have this chronic respiratory disease uncontrolled. Therefore, asthma still represents a public health problem in Puerto Rico, as Dr. I forgot his name, Landrigan was mentioning. It should be treated as an epidemic in the island. The program's health promotion interventions have been focused in providing capacity building to health professionals in the adequate use of the NAAP guidelines, and in providing evidence-based training and trainer activities to propitiate a multiplying effect in asthma education. The asthma trainers are certified to provide training to other health professionals and educate patients as well. Up to date, 2,542 health professionals have been trained in the use of these guidelines, and there are 188 additional asthma-certified counselors across the island, including home visiting nurses and other non-physician health professionals. Moreover, also in collaboration with its university partners, the program has reached about 175 teachers and school staff who follow indoor air quality practices and provide educational asthma activities. Next year, through an educational effort with the Medical Sciences Campus, 600 health school teachers will be trained in asthma and indoor air quality efforts. So we look forward to continue this partnership with in-home asthma interventions that can bring significant health benefits and cost savings to people, but more importantly, to improve the quality of life of people living with asthma in Puerto Rico. And thank you again for the invitation, and we look forward to work together with EPA and DHHS. Thank you.